All right, so.
You can't see me, so we would participate for medical.
Yeah. So good evening and welcome to the innovation competition. We have 4 teams here going to be presenting. The rules will be provided by Dr. Yanmala. The judges for the competition are myself, Dr. Yanmala, Dr. Grace Versosa, and we're delighted to have Dr. Adam Saltzman, who is the Chief Medical Officer of ECHO, to join us. And the whole purpose is to see 5 to 7 minute pitch on how best we can innovate using the new device. Dr. Yanmala?
So here I'm going to go with, so I asked everybody to send me a team name and their mentor. Only 2 teams send me their team name. So the other 2 team names, I don't even know what they are. So this is how I'm going to go with first team. I'll call out on a random basis again, right? And you will have, at 5 minutes, I will raise my hand to just alert you that you have 2 more minutes to go. And at 7 minutes, my cell phone will go with a beep beep sound. That's when you stop, at whatever stage you are. Fine? Best of luck to all the teams. And you already know what you will be judged on, right? Innovation, creativity, and inclusiveness. Right?
So you can't go more than 7 minutes?
No.
No. Created no rambling.
Me? Oh.
The first thing that goes is loved up.
Oh.
We want to start with the heartbeat. So that's the reason I want to go with.
That's us.
We were so ready to go.
That's fine.
Okay. Do you want to?
Yeah.
Take control. Presentation? No?
Give me my laptop.
Ready?
Yeah, I think you want us to present at the front of the session?
Mm-hmm. Yes, please.
Clock started.
Professional way.
Yeah.
Or is it not go back?
No, it's fine. Is it okay if we have
Yeah. Ready? Start.
Hi, everyone. We're Team Loved Up. I'm Megan.
I'm Mark.
I'm Bobby.
And we're going to present our project called Sounds of the ICU, Identifying Acoustical Signatures. So this is a brief outline of what we're going to be covering today and how we're going to go through it. So before we really jump into everything, I'd like everyone to just take a moment and listen. What do these sounds evoke to you? What do they mean? When you listen to these sounds, we already use sounds in our daily clinical life for many different things and are able to identify various disease processes. And that's sort of where we jump off into, and I'll pass it over to Dr. Rizzi.
So in the age of advanced imaging, where everybody gets a CAT scan and X-ray, the cornerstone of a cardiologist's physical exam is still via the stethoscope. However, the heart sounds we hear only tell our ears a part of the whole story. We're not able to perceive a lot of the extra information from those sounds. And what I'm talking about is acoustic signatures and phonocardiograms, which have been used actually for a few decades to identify, detect, and evaluate cardiac diseases such as murmurs, aortic stenosis, coronary artery disease. However, in the past, it was quite cumbersome to apply it easily to every patient in every setting. But with recent advancements in technology, and now with the echo stethoscope, which has the ability to rapidly, reliably, reproducibly create and store phonograms as well as single lead EKGs, we can, I think that'll, it'll add to our armamentarium to evaluate these cardiac disease processes. And there have been a lot of diseases where phonograms have been looked at, but a lot of diseases also that have not yet moved to the background. So in particular, phonograms have been used in our literature search. We found that phonograms have been used for durable MCS, such as LVAD, in order to distinguish the different types of LVADs and even figure out LVAD unique pathologies like pump thrombosis. However, we did not find any studies looking at using acoustical signatures for temporary MCS, namely Impella. And we have a lot of Impella patients in our hospital who may benefit from looking at this data. And so, so that is going to be what our project is focused on. And I'd like to move to the project idea
evaluate and guide our decision-making process with Impella. We use invasive, A-lines, pulmonary artery catheters, as well as non-invasive, echo, lab values, vital signs. But we haven't really used the sounds. And as Adi said, you can identify bad thromboses outpatient or inpatient. Can we do the same inpatient? So our hypothesis is percutaneous mechanical support has a distinct signature that can be recorded by the echostethoscope. The goal is then, can these signatures be monitored and correlated with patient care and outcomes to help predict weaning parameters, to identify these complications earlier, and to help remove them and guide the decision-making in a way that can be reliable and reproducible. We all know there's controversy over pulmonary artery catheters. Can this help to sort of guide or showcase some similarities and prevent that those challenges? So how would we go about implementing this project? First, we would identify and investigate 50 patients using mechanical circulatory support over the next 3 months. This is an easily identifiable population because once they are hospitalized, and 2 days of mechanical support. Every patient with MCS has a heart failure consult. So we already know which patients are going to be obtaining it. And if we're able to then record those sounds prior to implementation, if able to, or afterwards, on that day, we would record it in 4 spots, your traditional stethoscope spots, and look to see if we can compare those signatures to identify the best location. The VAD studies all use the mitral valve area with 15 seconds of recording to find and identify the best location. So we would use that as a jumping point of where to start. We would then record them at the various settings, going down P9, P8, P7, and see is there a difference based on the flow rates of how the phonocardio changes. And the way we would analyze that would be by looking at the intensity of the sound, the pitch, the uniformity of the sound, as well as using the baseline acoustical processing that has been already used on these before to see what the changes are. We would then compare these based on the settings, as well as also by recording all of the baseline data to make those next steps on creating the baseline, and monitor the progress throughout the hospitalization by doing daily recordings and keeping them in a, you see them on the app as well as correlating that with the one-time thing. So now I'd like to pass it over to Dr. Santel.
As the most junior member of Team LOPTA, we thought it was appropriate to talk about the future direction. So we hope that by utilizing technology provided by the echo stethoscope, we can create this repository of these acoustic sounds with the correlating phonography, and this will open up endless opportunities, we think, but we hope to focus on primarily enhanced teaching in this facility, and we also want to augment treatment and future technological innovation by what we're able to gather from this study. And with that, we will open it up to questions.
This is what our old stethoscope used to look like. You can see that in the picture.
Very good. All right, so you want to bring back the panel of the.
Just stop sharing the screen. That's it.
All right, so let's open for questions. So, Dr. Salton, do you want to ask?
Oh, yeah.
We should probably set it up.
Yep.
Have I been called upon?
Yes, so, yeah, Dr. Salman, do you want to ask questions?
Sure. So one of the things that we're always, I think this is a very, very interesting project. One of the things to consider, of course, is that you have multiple changing dimensions of parameters, right? You have the settings as one dimension, you have the patient's hemodynamics as another. What do you think is the most important endpoint? In other words, would it be the final removal of the device, or would it be when a change is indicated in the settings, or some other endpoint of clinical utility?
That's an excellent question. We were talking a bit about that because there are a lot of variables that go into Impella and mechanical circulatory support. For us, some of the things we wanted to initially see was, could we guide those weaning parameters to be earlier? So instead of having to wait to see, did a change happen on the lab values? Did a change happen on the echo? If you're at bedside, you put the stethoscope on and you see that the flow the sound of the, has changed, and that the photocardiographic has changed with its relationship to systole and diastole. Can we then move quicker to allow for removal of the VAD earlier, to allow for titration down sooner? Can we also, if you're worried about a complication, can we identify it earlier to prevent it from becoming something worse? So it has various applicability, and I think that's sort of what, when we do the photocardiogram, we can see how those change, to guide those to prevent, either future complications would be the goal.
Yeah, I think at first we have to get a data set of what the phonocardiograms look like across a number of patients at different flow levels in isolation.
Yeah.
And then later see if we can reverse that and use the phonocardiograms that we receive to say, hey, maybe this person is ready to go down a flow level or even be weaned off.
Interesting, the VAD study that came out earlier this year in Jaha, was able to identify quality of life markers to help actually increase and improve that patient based solely on the phonocardiograms in an outpatient where you're listening to it and you identify it before it becomes an issue. So that I think is a benefit.
I think that the fact that you're trying to use the echo stethoscope to be able to predict reading parameters from the tele. Now, my question is, sometimes these patients have multiple devices there, they may have some other sounds, so how will you differentiate noise from the impeller sound?
Yeah, so we were talking about that earlier as well, because you're right, sometimes people end up on Expella, sometimes people end up on RVAD and LVAD support. Sometimes they have different devices, and the fact is, we just don't have any of that baseline acoustical signatures now. And so what we're hoping to do is, the initial project would look at the individual Impella devices and make sure it's separated by group. So once you start to get multiple devices, I think that would muddy the waters until we are able to separate out the baseline characteristics. So it would have to remain your Impella CP, your Impella 5.5 for now, your RVAD, and if ECMO was there and it does make a signature, which we weren't sure about, ECMO separately. So the combination ones, we just don't have enough information to do yet.
Yeah, and you, because the parameters, one of them is the amplitude and all that, I think you should also include timing.
Absolutely, absolutely.
Okay, so I'm going to, first, who's your faculty member along with you?
It's Dr. Moore, he was unable to join us
Okay.
today.
Okay, no worries. But let me first start by saying that this is absolutely fantastic. Okay? This is very good, well thought of. Let me also present to you something that I like. There was a good, you guys have rehearsed it. There was an energy, there was a synergy in the presentation. And I think also I like the fact that you believe in what you're presenting. Okay, so that's very important. Okay, that's very, very good. I think this is this could be a very strong foundation. You're about on a starting point. I would use as an exploratory step, because the concept of how you want to use it needs to be developed. I would suggest you do multiple recordings in the same patient longitudinally. So you will have multiple sets of data points. You want to do it at different intervals of the day. So you have diurnal variations and you get high density of information per patient. And of course, the 50 is a good point to start. And then you can apply some advanced analytical approach to understand the correlates. And then you can correlate to outcomes of recovery. You can correlate to physiology related to all that. And this could be very rich. I see this is going to be easily publishable. This could yield very strong hypothesis. This could start off into a direction where you can pivot the use of a device like Echo for guiding management of patients in the ICU setting, particularly even by I would also think not just physicians, but also by paramedical workers and nurses and things like that. So congratulations, well thought out. I really liked it.
Yeah. So I'm gonna take one more judge. My question from.
Go ahead.
So, one question on statistics, right? Are you planning to collect multiple samples from the same patients or not?
We are.
Yes. So how are you going to control for inter and intra provider biases?
So we're hoping that the echo stethoscope sort of removes some of those biases because it's placing it in the specific specified locations, which we would all be trained on beforehand, and it records out the, and it puts it into the recording, so that way we can then analyze it separately from the patient, and then those correlate with the data. So when we do the invasive hemodynamics, that would be done on your daily rounds with the heart failure team, with the heart failure attending, to make sure it's as reliable at that point in time, and that would be the correlation to try to minimize some of those biases.
At about the same time every day in the same location, maybe, bed positioning and all of that taking into account.
Perfect. Thank you for answering that. And one thought of food for you is, how AI tools can actually be used to separate two speakers signals. maybe you should think about parallel for separating out your device signals.
Yeah, when you look at the LVAD, there are about 4 studies done with the ecostethoscope and the LVAD. They were able to distinguish, just by listening to it, you can determine heart rate 3, heart rate 2, you can determine thrombosis or not, and then they were looking and also separating out the heart sounds for stenosis or not. So that was using the AI. We just didn't delve too much into that part right now.
Yeah, so I think you're all good. Thank you.
Very good.
So the next team,
It'll be hard to top. Good job, guys.
what did you write, Adam? I couldn't read.
Andrew.
Buckman's bundle?
Yeah.
So next team I would like to call upon is Buckman's bundle.
Backman's bundle.
Buckman's bundle.
Looks like it's not a bundle, it's one fiber.
The other bundles are on the.
Fiber.
Oh, it's got integration, huh?
Oh, really good. It's gonna be mine.
You have to reshare, I think. It's faster.
Yeah. Not letting me open the main.
You have to click on the panel.
So it's me and Dr. Cornelis is my mentor on this project.
Yeah,
So
the top.
Oh, there we go, that's why, yeah, new share.
Just to the screen, right? It should be good. Just to the screen.
Okay, sharing, and then we'll just start.
presentation. So just to kind of start off on a practical standpoint, imagine you're a fellow or even an intern, and then you call you 3 in the morning and say, I got this wacky EKG, and they text it to you, and this is what you see. Of course, you freak out, and then you go down to see the patient and see what's going on, and go to the next slide. And then you see that, all right, lead placement's the issue. So you use the wrong place, and you put it back on the right place. And then you get a recent EKG, and the axis is totally different. So then you start to figure out, this is a Y complex tachycardia. Is this SVT with aberrancy, or is this ventricular tachycardia? So you rely on your training. What can I do to figure this out just on algorithms that have been published already? So there's all tons of algorithms you can use, Brugado, Variety, Lead AVR, and then you're like, oh man, this is too much. I can't memorize this right now. So what's something else you could do? Well, what if you use the stethoscope, the echo stethoscope, to use heart sounds to help figure out if they're showing VT or FVT with aberrancy? So this is kind of where I went with this. So basically the idea of, I look back at history, and I don't know, Dr. Samuel Levine back in the 20s, he noticed that people with VT, they had variable S1 intensity in heart sounds. So then in the early 90s, this group here, Publicists in Circulation, looking at basically specificity, sensitivity, and positive predictive value in certain diagnostic tools in diagnosing VT. And one of those was the variation in the S1 sound intensity. And it's pretty clever the way they did it. They actually paced, they had 2 groups of people. They paced one in the atrium at a fast rate, and they had one lead in the ventricle and paced really fast and see if there's something correlation. But as you can see here, the specificity and positive predictive value for S1 intensity was pretty high in this cohort of patients. So what I did, I went on the internet. I was like, can I actually find something to actually prove this? So this is actually, unfortunately, it's a canine, a dog. They did a study on this, and they induced VT. This is the phonogram right here on the bottom. This is the top, the EKG portion. Of course, S1, S2. And if you look at S1, when there's short runs of NSVT, short salvos of that, you see there's variations in S1 intensity. When you have normal, captured beats here, there's not much variation in S1. So, think of something else that we use in everyday cardiology to figure out, for example, tamponade, right? It's the exact same idea. Except in tamponade, you're looking at inflow velocities, mitral inflow, tricuspid velocity, you get variation, 25% mitral inflow suggests tamponade, 40% of tricuspid inflow suggests tamponade, help you kind of punch that diagnosis. Now, same concept with VT. I basically just took the same thing and I applied the same concept. What is the magic cutoff for S1 variation to predict the likelihood of VT? So that's basically my question. And with the stethoscope, I think the benefit of this, you could potentially increase the sensitivity diagnosis because it's more sensitive. You can pick up things that you wouldn't be able to pick up just normal auscultation. So what I propose is you could basically use the stethoscope, measure S1 amplitude variation. If you have patients in the ET lab, they're in VT, you can, do a subset of patients, look at that. actually measure out variation in S1 intensity, and I look at people in the ET lab that are in SVT and compare the two and see there's a difference. If there is a clear cutoff that exists, the question is, could you then program the stethoscope to listen to that certain time interval, say 10, 20 seconds, and it'll actually spit out a variation of S1 intensity, and it stays at 25% or higher, then, you got that information right there, and, sequence the diagnosis. One of the potential limitations of this is people sometimes VT have VA conduction and you don't have VA dissociation. So one thing you could do to tease that out is if you have patients that are in VT that have VA conduction, use the same stethoscope and see if there is a variation in S1 intensity just to kind of see if that exists. But basically, this is kind of what me and Cornelis came up with, and I think it's easily doable. Even you don't even have to be in the ET lab. Say someone comes with VT, they have a device, surrogate device, prove that they're in VT, and then you can use this method just to kind of map out, and you have 10 patients with that, and then patients who are in SVT, same thing, and kind of compare. So, yeah. Any questions?
All right, yes,
One second. You still have 2 minutes. Do you want to introduce your team? What do you do? And your mentor?
Yes, so my team is me, and then my mentor is Dr. Cornelis. Emily and Raj, but they're on vacation, so.
A lot of people may not know who is me.
Oh, Andrew, yeah. Okay, Andrew, third year
Which
fellow.
year are you in?
Yeah, third year fellow, cardiology fellow. I'm actually applying for ET right now, so. But no, I figured this would be a good practical question that the answer, I think it even helps the fellows out. It's cumbersome. It's hard to tease out the little details, and I think this could kind of add to it.
Like, what is the motivation? Because you still have your time, so that's why I'm killing it.
Yeah.
What is your motivation behind doing this? Like, what motivated to go with this particular problem?
I think it's a problem that we encounter all the time in fellowship. I mean, we get this all the time. We get called from the ER for someone who's in light complex tachycardia, and I think delineating the two obviously influences the treatment. You're going to treat some of these differently than some of these SVT. And even these algorithms that we go by, they're not 100% foolproof. One of the biggest things we look for is see if you can find evidence of VA dissociation, dissociation on the EKG, but sometimes you can't find that. And maybe with this device, it's sensitive enough that it can actually pick it up, and then bam, you got your diagnosis. So.
Thank you, Andrew.
Sure.
So open up the questions for the judges.
okay, all right, so we'll go the same order.
Dr. Sal.
So would you expect this to be eventually an artificial intelligence machine learning algorithm that could discriminate by looking at the amplitude of the S1? Or would you expect this to be like a manual measurement exercise where you would record and then sit down with your calipers? You guys still use calipers, right? No, you don't use calipers, okay.
I think the end goal would be where you can have artificial intelligence where it can actually tease it and actually spit out a number for you. I think that's the end goal, but I think obviously in the beginning stages, you would have to kind of manually figure it out and tease it out that way. But I think that's the goal, is that where you can program the device to actually do that and give you a quantitative reading instead of a qualitatively listening, so, yes.
Great. So when I was listening to your presentation, it reminded me of that distinctive R-wave notch in the EKG to predict the presence of atrial septal defect. Actually, I did a study on that, but it didn't go well because there is a lot of variation,
Yeah.
So that notch you don't really see much. That's why you don't really use the EKG as a diagnostic tool to diagnose atrial septal defect. And then the second question is, what is it, after I got lost in your presentation, what did you want the echo to do to differentiate SVT from VTAC?
Correct, yeah.
Okay, so that wasn't kind of clear in the beginning. Okay.
You have tough judges, huh?
Yeah.
Yeah, you go ahead.
So one question I had was, does the time lapse between the different signal variation that you're showing, is it consistent across the patients, or is it also variable across the patients, depending upon the patient?
As far as when you record the information, so you could start out with a 10-second time interval. If you're not getting enough information variation, you increase to 20 seconds. I guess we're just kind of.
And the S1 and the S2 variation, does it change depending upon age or
type
of the?
Yeah, there's a lot of different things that vary. That's one. I mean, even the PR interval, or there's a lot of factors that can. Now, I think one thing you could do to tease that out is that you look at people who say they're just sinus tachycardia rates of 140, and just, I'm sure there's gonna be normal S1 variation with those people, but compare that S1 variation to people that actually have VT, and see if the variation is significant enough to delineate the two. So that's kind of the idea.
And can you reflect upon how do you plan to conduct your study, because I did not see a study plan.
Yeah, so like, one way is, you have somebody in the EP lab, and if you have, you have all the catheters in the heart, intracardiac catheters, for sure they're in VT or not. And that way, if they're in VT, you can use the stethoscope to actually, get your information. Another way is if someone comes in VT and they have a device, ICD, you interrogate it, and just through interrogation, you can know for sure what the rhythm is, and then you can use that, to know for sure, and you record, and get information that way, so. Those are two ways you can go about it.
All right, so, my job is always to, I love, let me ask you a question. This is your brainchild or Dr. Karmala's brainchild?
It's mine.
Is yours?
Yeah.
Is that true?
His brainchild. It's all his.
Okay.
Unfortunately, the other
Okay,
two
so I have to
members were on vacation, so the other two members
Okay,
were on
so I-
vacation, so we couldn't,
Okay.
it was all Andrew.
Yeah, so that's great. So I think you came up with something which is relevant. I want to give you importance. So basically, when you are in the middle of the night and you get a bronchial tachycardia and you want to wake up your, and you're alone and you don't have anybody else, what do? You need help, right? So you're trying to break it or shock it, or what do you do? So maybe you're providing some assistance. So I understand that. I also like the idea that the model that you're going to test is going to be very perfect, because it will be done where you have the absolute ground truth, because it's an invasive environment where a VT is created and you're recording it, and then a speed is created and you're recording it. So I like also that environment. Now, so I understand the potential. So one of the places where you may struggle with is that in the design is, as Navina was pointing out, the variability that comes physiologically. I also worry a lot about atrial fibrillation.
Yeah.
That could change the intensity of S1. But having said that, I can just clearly see that you probably need a method, a better method. One of the methods that you could use, and Navina, a person like Navina can help you with, this could be seen as an anomaly detection. So basically, you can say that, hey, you know what? This doesn't look physiological. Doesn't look like a supraventricular tachycardia regular. This could be high probability of a VT or something. I mean, those are the ways you could develop some machine learning modeling. But if there's a good amount of data sets that you can collect, then there's an outcome that you can look into. It will all depend upon how you will develop it. If you have a good data set that you can collect and harvest, then high likelihood of something could emerge that could be used. And I already see that this could be very useful for resource poor, constrained settings and in emergency rooms or ambulances and where people are struggling, and so I think I see some value to that. So congratulations on at least thinking through something which is important. Any other questions, thoughts?
From the other faculty? Yeah.
I think that the beauty of this is the ease with it. So I think a lot of the critiques actually are not applicable. If you do this in the EP lab, you know with 100% certainty what the rhythm is. So there should be no question of other arrhythmias. AFib wouldn't be an issue because you know they're not. And we can tell with 100% certainty if they're an SVT or VT. We have a constant supply of patients. We did VT yesterday. I have an SVT later this week. So it'll be easy to find these patients. The patients can act as their own control, which is nice. And the EP lab itself, when we're doing this, is a completely quiet environment. So it's probably a perfect environment to sample acoustic signals. So I think it'd be really easy to get patients and really easy to do.
Implement. So I agree with what you say.
And Andrew, to your critique of yourself with the VA conduction, if you're in the EP lab, you get adenosine. If it's VT, you will dissociate.
Yeah.
So you will be able to do that under control conditions.
Yeah.
So I think, as to what Ted said, he has his own control within the same patient.
So I wouldn't do just only 10 patients. I would do a large number of 40, 50 patients, and develop a database, and then you will have a nice way to.
So my next question about, right, if you get to do this, do you think I know that you single-handedly did this because your partners were in crime, were on vacation, right?
Yeah.
So do you think you would be able to finish this then?
Yeah, I think it's easily doable, yeah, absolutely. I think like they said, we have a plethora of patients in the EP lab, and even if that's the limitation, I mean, we get calls all the time with people's devices in the ER, we know how to interrogate it, we got the rhythm there, after we interrogate the device. So, yeah.
All right, okay.
So next I call upon the underdogs to show us what do they have under their keys.
So we pull the PowerPoint.
That's good too, right?
Oh, the team name is called Underdog. Wow.
Break pressure, that's so.
Love job, underdog.
Team Andrew.
They were.
Bachman bundle.
All right, you can drive.
Okay, let's focus. No cross talks right now. Let's focus.
All right, so, I just wanted to start by saying thank you to Dr. Sengupta, Dr. Yanamala, Dr. Rizzosa. It's nice to meet you, Dr. Saltman. Dr. Casoda sends his regards from the back of the room.
Yes.
Let me just get this here. So in either case, piggybacking over some overlap with this, one of the growing, population of patients we encounter every day are heart failure patients, and there's a lot of, even including EP aspects and other aspects, there's a room for growth in terms of artificial intelligence. So without further ado, our topic is, heart failure management and machine learning using echo digital EKG stethoscope.
Yeah, and just to introduce ourselves, I'm Varun, this is Jan, and of course, this is
I'm Sadie, nice to meet you. So just to briefly go over the background of this, there's prior studies which I'll reference shortly that have shown efficacy of artificial intelligence enabled EKG algorithm in identifying LV slug dysfunction with an EF of less than 35% using 12-lead EKGs, and have shown supportive data to that. And to that fact is another study published in AHA in 2019, which was a smaller population of 100 patients, but it did demonstrate that using an AI algorithm, you can train it using 12-lead EKGs that then are applied to single-lead EKGs, and therefore can reliably identify heart failure with reduced ejection fraction. And these are those, we have the references at the end, but these are the 3 of those 6 studies we found that support, the findings here and laid the groundwork of using artificial intelligence in predicting heart failure with reduced ejection fraction. So therefore, that then raises the problem. Heart failure has, frequent readmissions and high hospitalization rates. And just to quickly review the costs, Dr. Moyne is here, and it's something we were very well aware of. There's 11 million physician visits per year for, that relate to heart failure. The cost in 2012 was $30.7 billion, projected to be $70 billion or so in 2030. It's more hospitalizations than all combined forms of cancer. And in addition to that, of course, as we, the baby boomer population, et cetera, there's predicted to be more than 8 million individuals with heart failure in 2030. And the average cost of an admission for heart failure is about $10,000 per night. So the economic manifestations are humongous here. And as the graph shows, which we've reviewed in the past, that heart failure is a progressive disease that requires multiple admissions and with worsening quality of life. So this is a disease that we'll frequently encounter, and despite our best therapies, we still have not really less of profound, improvement in terms of quality of life and management. Which leads to my next counterpart, Varun.
Thank you, Sadie. So as Sadie explained, heart failure is a huge problem, and our goal is to attack that problem using the EKG-enabled echo stethoscopes and applying this AI-enabled algorithm to detect heart failure, reduce EF. What we want to do is incorporate pro-BNP measurement as well, and train our algorithm using pro-BNP in our set of data as well. And the goal will be to really use this to give prognostic information and predict also who's at risk for readmission. So aside from just getting an EF or detecting reduced EF or preserved EF, we want to use this as a prognostic tool as well. And that has multiple applications, including creating a monitoring program, using it in the outpatient setting to decrease heart failure hospitalizations, and also addressing key disparities in care. Next slide. So this is a visual representation of what we plan to do. So combining EKG data and transthoracic data, creating that pair, that's a pair that a lot of prior studies have used. We want to introduce NT-proBNP and then take that data and train a neural network or artificial intelligence-enabled algorithm and with that data. And then we can apply single-lead EKG data from the echo stethoscope to predict reduced ejection fraction, and then also potentially predict who's at risk for heart failure rehospitalization and who has a poorer prognosis. So for our study idea and our methods, we want to also potentially optimize this algorithm to allow for more accurate prediction in narrow ranges. So not just predicting like prior studies have low EF less than 35%, but also looking at 35 to 45%, 45 to 50%, putting people in different ranges and stratifying them. And so as you can see in this figure right here, there's different key positions, auscultation positions, where you can get data at each position and obtain different leads. And that data will all go into this algorithm to get an idea of what their EF is. And of course, you're going to have a transthoracic echo on all of these heart failure patients come in, and a 12-lead EKG already, and a proBNP. Right. Now I'd like to hand off to Janet, who's going to talk about a little bit more, build on the clinical relevance.
Sure. So to reiterate some points that Varun and Sadie have already commented on, we believe that our proposed study can have a strong clinical impact on caring for our patients. ECG-enabled stethoscopes will allow us to sort of detect reduced EF in a quick and inexpensive fashion. This includes both in the inpatient and outpatient settings, at point of care and for follow-up purposes. We believe that early detection of reduced EF at point of care could actually enable earlier risk stratification, workup, treatment, including diuresis, which can take days for patients that are in the hospital, as well as initiation of guideline-directed medical therapy. So this would reduce overall hospital length of stay and thus healthcare costs. We'll also be able to monitor EF in the outpatient setting during follow-up visits to identify worsening cardiomyopathy and patients at risk for rehospitalization. We hope to ultimately be able to incorporate this also in resource-poor, low-income settings where follow-up testing may be less feasible, maybe too expensive for patients to afford. Some of the resources we feel we would need, of course, we would incorporate our ECG-enabled stethoscope. We would need a 12-lead EKG, average cost of which is around $40 to $50. Dr. Singupta has kindly provided us recently with a new pocket ultrasound. We feel like we'd be able to use this as well to verify EF at just point of care. We would also ultimately want to complete 2D transthoracic echo to accurately assess and confirm that EF, especially as we're kind of training this algorithm. And we'd also need routine lab work, including a proBNP, average cost of which is around $37. In terms of future direction, so we hope that to do our study to kind of do a large-scale prospective validation of the echo ECG-enabled stethoscope's ability to detect reduced EF and accurately predict that EF as well. We feel that that part is still needed because the prior studies were much smaller scale.
Thank you.
Oh, so is it? Yeah. I thought we were going to warn.
Yeah.
All right.
Impedance was the highlight, though.
That's the future.
Right.
Very good. So, okay, again, we'll go back to Dr. Salman for this question.
Well, it's not really fair for me to ask questions because those papers were ones that actually some of our ECHO authors wrote, and we have a single-lead ECG low F detection algorithm currently preparing for FDA submission. So it's, I probably have some background, but I have some questions for you about the interesting addition of proBNP. So considering the population you want to study, it sounds like it's mostly stage C and D heart failure patients who are showing up with symptoms. What do you think about identifying patients who are earlier, like in stage B heart failure? And how would you do the study to pick them up? And how would NT-proBNP play with that?
Well, NT-proBNP, as we know, like it has prognostic value. It can help us predict risk of rehospitalization. And also, with the EF, we can predict patients who are at risk for sudden cardiac death. and at risk for rehospitalization. So at this point, we hope to incorporate that and see with the algorithm whether that NT-proBNP will help us capture people who are stage B as well, and take patients with not severely reduced DF, but also just mild and moderately reduced DF. But I think we'd have to explore that further and see whether, we, with just NT-proBNP alone, in addition, that we're able to really look at this group as well. Perhaps, it's certainly possible that other parameters as well, including age or gender, could play a role and be, incorporated into our algorithm as well.
Or if like the single lead EKG has a certain like fingerprint, that might correlate with a certain degree of, reduction in EF, being severely low or moderately reduced, whether or not it correlates to some, feature of it, whether it being amplitude, whether it being variability in terms of the single lead EKG. It's kind of one thought we had in mind. Just the other addition we're debating here, of course, including that impedance of the echo stethoscope itself relating to volume status, as maybe like a point of care ultrasound in addition to it. Let's kind of expand this in the future, because that would give us a quick idea of the.
So that's one point I want to make is that, we have a set of features already, but the RASC impedance for monitoring of volume status is something that's valuable. It's a good objective measure. And, that's something from a hardware and software standpoint, if we can incorporate that into the stethoscope itself, and then we could monitor patients' volume status along with, we can extrapolate more data rather than just the EKG and the heart sounds. We can maybe get an impedance, just sending a signal and detecting that signal and get an objective measure of their volume status as well. And that would be something that you can follow more longitudinally in the outpatient setting as well.
And preserved ejection fraction heart failure too, which is a whole other host, that we need to.
I was going to ask you about that, but before I let go, I have one more question for you. You talked about the cost per patient very nicely. How many patients do you think you'll need to construct this model?
So, that was a topic for debate. I would imagine it being at least 50 patients or so, particularly if we're interested in diagnosing it or picking it up for a new diagnosis. I'll say in the outpatient setting, because that would be very profound.
Yeah, I think, prior studies have looked at about 100 patients, and I would like to do more, like at least 150 to 200 patients overall to build on that.
So my question is, so this study, you're trying to validate each echo for detecting heart failure, and you want to compare it, or at least train something using echo, EKG, proBNP, what else? Pocket ultrasound.
Yeah, we could use pocket ultrasound, and then we could also incorporate age and gender as well.
I think, for me, I think you have so many parameters, it's becoming more expensive. Why don't you use just one gold standard to?
Yeah, I think the main thing is the proBNP that we want to use.
Yeah,
that's the main
if
focus.
you use single lead EKG and a DNP, and then see if it's better pick up heart failure, especially with exacerbations. And then apply it to especially clinics that don't have access, or patients that, or socioeconomic status, or hospitals nearby. All you need is just these things at your disposal, and you just practice.
Okay, so as I always do, I always start with appreciation. I love the energy, right? You guys prepared, right? You rehearsed. You had a pitch, nice pitch, and everything, it makes sense. That the second is a statement about the problem. This is a real problem, and that's why what you are proposing is what ECHO is actually trying to do. So this is a real problem. So the problem is very genuine. Where I find a little bit of challenges, and it's not because you're trying to do this for the first time. So I think maybe we need a little bit of guidance and a little bit of Dr. Christodis and all probably can bring in a little bit more nuanced understanding. So there are some challenges here. Okay, the first challenge is you cannot train a new model with 50 patients. So you will be very, very sparse in your ability, number one. So the sample size for a neural network typically is very large. Now, there are methods for doing what is called as transfer learning, where you can transfer a pre-learned model. For example, if Dr. Salzman becomes very excited about his project, he may say, I have this model, and you can retrain it or tweak it further with some other things. That's called as the transfer learning. You can do it in a smaller subset. You can do. But I think I found that we are not so sure about how we can use machine learning here. Now, if you want to use a pre-existing model to validate anticipation, maybe it's okay to think about that. But again, there are certain challenges. Now, I'll tell you the other challenges. So, NT-proBNP is good, but it's not great. And it does not go linearly, doesn't work very well in heart failure, preserved ejection fraction. And so I was very unclear what subsets were you. So for example, if you were to go and include heart failure preserved ejection fraction, then it will be a big problem because it will not work. And there will be other confounding variables, obesity and, other things that can really could challenge you for using that as a gold standard. So NT-proBNP, therefore, is not a very good, it's a marker we use, but it's not a great marker for us to think about developing a neural network. I mean, so that's a slight limitation. And this area is very problematic because I didn't see where you're trying to predict a person going into heart failure. So as Dr. Salzman was saying, stage B or going into stage C over time, whether you are trying to predict elevated filling pressure, which is completely different, by the way. And the neural networks have not been trained as yet, to the best of my knowledge. ECG has been trained. We've done some work on elevated filling pressure, but it's a completely different target. So I thought there was a little bit of the novelty point of view was a little bit unclear, but that doesn't mean that the area on which the area is very genuine. The application in this field is going to be very important, but I think there was a little bit of how do we apply and how do we use it and do it requires a little bit more work. Sure. But I think this is an important area. Yeah, Navina?
No, I really like the way this was very unique organization of the presentation where we actually thought about burden and then the need and the impact. So it was very kind of thought about in a research way of doing things. So I want to appreciate your team for that.
Thank you.
Thank you.
Yeah.
I think you're gonna need a larger sample size.
Last but not least, the right pressure is the team name. And who was your mentor?
Dr. Casola, Yeah, thank you, Dr. Casola. We appreciate your support.
Okay. Well, we are the Right Pressures. I'm Joanna Rock. I'm the third year.
I'm David. Lindsay, I'm one of the second years. I'm Albert, I'm one of the first year fellows.
Yep, and our mentor is Dr. Moyne. So our basis of the project is, can a machine improve our physical acumen for pulmonary hypertension?
Use the arrows.
The slides are the old slides.
Okay.
Oh.
Is it not
You meant to
sharing the
reshare, you meant to reshare it.
It may not be sharing the correct
The
PowerPoint.
correct one, yeah. Where's the middle?
Yeah. Let's go to the. No.
Where's this? You're actually-
Oh, I see. Right.
You want to read?
Yeah.
Okay. I can.
Please show the first slide and then go to the next slide.
Okay.
And next slide.
Okay. So hey everyone. So we all know pulmonary hypertension is a widely accepted underdiagnosed condition that has massive implications on the global burden actually, and global disease burden. About 3 to 4 million in the U.S. are diagnosed with pulmonary hypertension. That's heart disease. Sometimes are often too late. Even group 1 PH, 6 cases per million. The problem is that the diagnostic features tend to be not very specific and often elusive. So John is going to talk a little bit more about the the sensitivity of the features that we have now?
Yeah, so we looked into our current physical exam for pulmonary hypertension, and in words of our mentor, it's just garbage. The sensitivities are very low. So if you look at the people who are the first line of defense, your family care doctors, your internalists, their sensitivity percentage when evaluating for the most specific findings for pulmonary hypertension is somewhere around 30%. Hopefully fellows do a little better, but even our subspecialists, their highest sensitivity is only around 50%. So there's a large section of patients who are being missed by physical exam, which is really our gateway to diagnosis. However, when it is heard, it is a very high specificity, almost 100%, 98 to 100%. So when you hear it, you know. Now, the whole basis of our project is when they looked at specific acoustic samplings within the accentuated P2 sound, and we're able to specifically create a sort of algorithm for those specific acoustic samplings, and then use a computer. They played the digital sound recording, and we're able to actually increase sensitivity around 70 to 75%. So the potential for an accentuated P2 as a physical exam finding and the diagnosis of PH is there, but unfortunately our human ear is not able to detect it.
So this is just some of the diagnostic schema that we currently have. There are non-invasive approaches and invasive approaches. Of course, right-heart cath is the gold standard for diagnosing PH. And of course, echocardiography on the non-invasive bucket is used as well. However, its sensitivity in diagnosing PH is relatively high, but its specificity is 72%. Physical examination is our it's the first test that we could possibly do. We found that accentuated second heart sound is actually very, very sensitive. Very specific for diagnosing pulmonary hypertension. So what we propose in our schema is, can we use this echo stethoscope, which allows for dual EKG and digital phonocardiograms to improve the sensitivity of the physical exam in diagnosing PH, at least, earlier diagnosis for PH.
Okay.
So our design would be to examine patients before they're undergoing right heart catheterization using the echo stethoscope, and we'd be looking at an accentuated P2 that would be oscillated, and the magnitude of the P2 on the phonogram, and then we'd correlate that with the mean pulmonary arterial pressure on the right heart cath, and then we'd see does the echo stethoscope improve the diagnostic sensitivity of physical exam in patients with pulmonary hypertension. So can we detect an accentuated P2, and is that correlated with invasive pulmonary arterial pressure? And then does the phonogram magnitude of P2 have predictive properties for pulmonary hypertension?
Yeah, so we're looking at categorical findings as well as quantitative as well.
I mean, if you have some more time, there's another data point that we were looking at in the study. They looked at the splitting of the second heart sound, and some of the papers show that the degree of splitting actually can give you prognostication of severity of pulmonary hypertension. And our little handy echo stethoscope can actually do that. So we thought, hey, we have all these patients coming in with pulmonary hypertension undiagnosed, right there in front of us in the CCU bed. It doesn't take 5 seconds to put the stethoscope on, gather some data, and create a database until we can run this.
Yeah, so in the last 2 minutes, Dr. Moyne, do you have anything to add as far as how you think this would be helpful in pulmonary hypertension groups?
I mean, as you mentioned, there's a huge need to better diagnose and earlier diagnose this disease. So the physical exam is the gateway. So I do believe using technology to augment our ears, which are limited in their capacity, will be helpful. So.
Fantastic. So now let's open up the panel. So Dr. Saltzman, you want to
Sure. There's a whole bunch of questions actually, because we're very interested in pulmonary hypertension as you are for the reasons you suggested. But one of my questions, starting in no particular order, is how many right heart caths are you doing for evaluating patients for pulmonary hypertension, or are you going to take all comers who are getting right heart caths, like prep for valve surgery, et cetera? Because the N is going to be an issue, right?
Yeah, so our initial plan was to take all comers going for right heart cath, because we also need to evaluate a baseline. Okay. Our initial plan is to take all comers for right heart cath, because we also need to initiate a baseline, especially in talking about the magnitude of the P2 sound on the phonogram. So we need to establish what the normal magnitude would be and compare that to those who have pulmonary hypertension. So it would be everyone who gets the right heart cath. We tried to make an assessment based off of using the stethoscope and the listening for the P2 if they have pulmonary hypertension, and then compare, but then also collecting the quantitative variables as well.
And so you think you have enough patients with all those right heart caths to do this in a reasonable amount of time? Because remember.
Yeah, I think so. We do a lot of right heart caths, and Dr. Moyne is growing our pulmonary hypertension population, started trying to create a pulmonary hypertension clinic. Just in the consult service alone this week, we're sending 5 or 6 patients for right heart cath, and that's just within the consults. If you also include the variables of CCU, those in the CTICU, and then those who come in from the outpatient setting for right heart cath, I think we probably easily do 10 to 20 a week and can probably hit, within 2 months, 100 patients.
Not all of them are done in the CCU, we do them bedside as well.
Yeah.
Okay, great. Do you think there's any value in adding ECG to your diagnostic algorithm?
Yeah, so the ECG is going to be really helpful, especially for timing of the P2, because we would expect it late on the T wave. And so, as a clinician who's trying to figure out what the P2 sounds like, especially if you've never heard it before, using the EKG to help you in the timing really helps. So, I think it would be very helpful.
Okay.
Okay, all right, not to reveal my age, but when I was training, we really listened to the heart sound, and I really know what that accentuated P2 is, and that it really reveals that elevated pulmonary pressure.
Yeah.
So you guys are very lucky that we have this technology, that you don't have to close your eyes and try to really listen clearly where that, and even the splitting of the second heart sound is something that you can actually hear if you really have to focus and really, concentrate. So I really like the value of this study because it's very simple, it's very practical, and we have to diagnose pulmonary hypertension, or even at least give the primary physician an inkling that this patient has abnormal heart, maybe elevated heart pressure. And if you can incorporate that in your echo stethoscope, Adam, that if this is here and the splitting is like this, then maybe you can have a roll in or roll out pulmonary hypertension. And it will really help in our physicians. Yeah, good.
I agree. I mean, pulmonary hypertension is the top of the funnel, and all of the other diseases come down from it. So yeah, picking it up is key, ruling it out is key. I agree.
All right, so I think lots of enthusiasm for this project, and I really feel like this is a very practical, pragmatic project, a very high yield project in terms of its applicability for clinical practice, and we definitely miss a lot of pulmonary hypertension. So well done, your pitch was very good. You did a very good trick in calling in Dr. Moyne to share his thoughts, because you really accentuated and you made sure that you have the top level of help available. So not everybody did that, so I want to applaud you for asking for the help when it is best time to have the pitch. So those are wonderful. Now, my reservations are for, since you're only evaluating patients who are going in for right heart cath, there could be a selection bias. because, you will not be able to see everybody. So, I mean, I would suggest, having maybe two cohorts. One cohort that is going for invasive, and, maybe also having another cohort, or at least having some way you can look into confounders, or at least maybe people who are referred to echocardiogram, right?
Right.
And see if there is no systematic bias. That would be one thing that I would make sure that you're not having as you're training your model. And I think I also agree with Dr. Saltman's point that you should definitely use the EKG also, because both the tools may be together, maybe different aspects of the ECG. So I would suggest taking the ECG and decompose the wavelets and see its relationship to the pulmonary pressures. And if there's a way and the data is large, I would actually suggest developing a machine learning model, not just going into a statistical model, but developing a machine learning model. And initially, you can start looking for binary outcomes like presence or absence of pulmonary hypertension, but then you could also look for maybe grades of pulmonary hypertension and see the severity based upon different attributes. So I just see this getting translated very quickly into paper and getting through journals and having a high practical applicability. So well done.
So I request all the judges to be here and the external faculty who did not participate in any of the competition to stay inside the room. And
Or
everybody.
maybe we go outside.
Yeah, we go out. Adam is not here. Adam is here.
I will call him on the phone.
Okay,
So,
sure.
Yeah.
Okay, we will go out. You guys
I'll
stay
come
here.
back and tell you the.
Bobby, you wanna join?
Yeah.
Great job, everybody. Great job.
We come back. So, just you can.
So if
mute.
you look,
You can mute yourself, Dr.
echocardiogram's only like 80% sensitive. It's
So Jim, I'm sure we'll talk, I'm sure we'll have a chance to talk again.
Does that be like if you're screening tool?
So, I want all the teams,
Wow.
I want all the teams, except for your team, give me 1, 2, and 3 of the most likable project that you like from your colleagues, right? 1, 2, 3 order. Do not grade yourself.
Okay.
You understood me, right? And give me I need 4 cheat sheets from all the 4 teams. With your hand.
So we put ourselves 3 years saying and all.
Out of the other 3, you raise your hand.
Oh, yeah.
Is this by person or by?
Come on, Paige, don't leave me hanging.
I would check Fadi's ballot.
You know, before that consultant went off, I was like, hey, I'll buy you drinks if you rank me 1.
It's gonna be like heart failure, heart failure, heart failure.
I'm gonna be okay, because I don't want to.
Hey, where's my team?
Janet, which,
Wait,
so what are the names? Which other one do you like?
I like the,
I don't know.
I have to say, watching this from the outside, it reminded me a little bit of Shark Tank.
Reminds you of what?
Shark Tank. Have you ever
Oh.
seen Shark
Yeah,
Tank?
that's exactly what you said.
Bobby, do you have a book, please?
Yeah, I like that too.
We don't have a post-it note. There we are. All righty, team. Which ones do we want to do?
It's gonna be.
So love dub, right?
Yeah, just love dub all 3 of them.
What were you called, Nate?
Love dub.
Wait, why are you asking so late?
No,
Just the judges.
just the judges.
I got it.
What was y'all's team's name again?
I gotta go
Right.
to the
Oh, which one?
20 minutes.
The underdog.
Stockman bundle.
Right.
Her name is Clarice.
I know it's
Hello, Clarice.
You know, but
Dude,
Right? I think it was the wild.
Yeah.
And
we
see all that going.
Celsius wildflower and not the other. It's literally I was wearing my mask. I was like, oh, it's very oh my god.
No, and then you're like, just like the inflow
And then
of
they're
like
like, who's your team? And you're like, me and Dr. Gertz.
It was like it's all Andrew, man.
I know, that was so cool. Was this your
I feel like.
Oh my God. Yo, we're like, you're like the hidden, like everyone's doing their game sheets, and then like game day, like there's this guy who scores 30 points, and you're like, what the hell?
Yeah.
Yeah. What's it on the tape?
I think he got a lot of questions, like, what's the tip? I was like, dude, so many questions.
It is, but I don't remember. I actually have like,
All of them.
no, I have one of these, sitting next to my backboard, and I just go for a flight. You almost grab both of them on one. Yeah. Oh, no.
Oh my God.
Before 50.
I know. You guys are so weird.
Let's hope they forget it. Don't mention it.
Yeah, no one will think, what are we?
No, no.
Second part of the
It's like the Squid Games.
That's not a thing.
You are. I don't think you're gonna get.
I feel like we're about to get shot in a second. Like, I'm the old man. Player, team, player, 115, eliminated.
Yeah, it's coming into your.
Oh my God, we're like, player, 125, eliminated. Player, love the one, eliminated.
Are you serious?
Yeah.
Oh my God.
Baby.
Look at that.
Oh, it's a card. My bullet. It's a quick game score.
Yeah.
He's going out for drinks after this.
Wait, what is this?
Where did that come from?
It's in there.
I'm gonna go get my baby. I'll do like a Zoom drink.
I think it's,
No one's
I think
gonna
it's
pick
somebody
up my
like.
baby.
This is an event that passed.
Up a little bit.
That's so cool.
Halloween party, right?
I don't know. Maybe on the parkway, like.
My mother watches Squid Game, so when I tell her I got chosen.
Oh, no.
Okay, it's very, pressing.
Yes.
So I want your choices, please, yeah.
Oh.
I also asked them to rate their own.
Okay,
If we win, I promise you drinks.
all right.
This is another team.
So the teams have also rated themselves, so let's see, what do they stand, so.
Oh, God. Kind of really.
Okay, all right, so I think this is, first of all, we'll talk about the judging and how did we, I think there was a very strong consensus, I'm gonna say about that. So the consensus was that, the pulmonary hypertension was really well thought of and was number one. It was,
I have to say that even the peer teams actually gave, 3 out of the 4 teams actually graded pulmonary hypertension as
So
a
there's
top.
a very strong consensus on that. Number 2, on the project was the mechanical circulatory, support and the heart sound.
The team is loved up, and the first team is right pressures.
Okay. And number 3 was, the, VT, SVT, differentiation. And heart failure, not that it was not important, we thought that there was a lot of work and a little bit of lack of focus.
Novel teacher, because
Novelty.
Dr. Salzman himself said they're working on it, we published something, so I said 3 categorizations of the things, so based on that.
Now, we announced the winners and the order, right? But I made a deal with Dr. Salzman.
Dr. Salzman,
So Dr. Salzman is going to give you all. And all the 4 projects will be done.
All fellows.
Wait.
No,
Well, maybe someday. Maybe someday, but for now.
So we'll get 2 more, so we'll pursue all the 4 projects. And whatever the weaknesses were identified will be corrected. And I think for all the 4 are publishable and we can create manuscripts. So I think, thank you for the great effort. Any feedback on how did you guys like the whole exercise?
friends, and what did you like, what did you not like?
I mean, we kind of went on a limb with like the PowerPoint that I think all started within the recent time, because there was no real, is it just verbal pitch? Do you want me to talk about a PowerPoint and discuss it in front of the crowd? I think the timing, like, we just want heads up before the end. These are the two main things, you know, there was no alarm or like a penultimate, you know, like warning.
I think what I've noticed is that when, more of us come together, the ideas get much more flourished. So I think, in future, when we do this, you know, I would like to be a little bit more collaborative. Everyone, you know, sitting down trying to figure it, and we can divvy things up, you know, so I think that was.
Any other points, anything else?
President.
It looks like a sparrow with some fun.
But what I want to say is that, look, this is a fun way to learn, right?
Yeah.
So within a very short period of time, you went through a lot of effort, you know, the collaboration, you have a direction, innovation, you're thinking through, and this is much more fun, right? And you're innovating, and so this is, but that's the spirit, right? So, great, thank you everyone, and I want to thank Jim, and also.
Can I take picture, Dr. Singh?
Oh, yeah, we need to have a picture.
So can I have
So let's come on here so that we can have a picture with the people on the panel.
Panel, yes.
So like all of us apart?
Yeah, all the 14. All the 14. Oh, you can do it.
Okay, so can I have each team separately so that I can have Dr. Kaufman as well in the, each team?
Well, he's.
Yes, come on.
Right here.
One second.
Come in the center, come in the center. So also be very, you know, remember where you're going to stand, where the people are going to look,
Thank you.
right? How you're going to.
Next team? Yeah.
Pulmonary
Nice
hypertension.
pressure.
Alberta has to leave.
The cardioversion.
You wanna actually handle it?
Oh, yeah.
Winning team, yeah, hypertension.
So this, you get the pulmonary hypertension.
Bravo.
You're blocking the camera.
Oh, no.
Can I have the lab doc team come up, please?
We get one for our team.
So the other one will also, two teams will also receive it.
All right.
How do we want to handle it?
I want Dr. Kaufman also in the team,
Oh, that's funny.
All
Smile.
right.
Thank you. Then the underdog.
Awesome.
You actually need both parts.
We need both.
No, there's another.
Yeah, you guys actually only have the listen to, we have the actual,
Oh.
so you guys can use that part for the project and we'll use this part for the project.
Thank you.
I have a question. You know what? I've been holding on to the entire time, like holding on, trying to figure out how we're gonna do them.
Oh,
Okay, bye.
We don't